Hello, everyone, and welcome back to It All Starts Here, a podcast focusing on the communication and education of topics in reproductive science and women's health. I'm your host, Olivia Moir, and we are back here today to talk more about gene therapy. You might have already listened to our first episode on this, which featured Professor Simon Waddington, and he gave us a broad introduction to this field. And if you haven't, definitely go and check that out first. But today, we're going to be continuing that discussion with the wonderful Dr. Rajvinder Karda. Dr. Karda is both a researcher and professor here at the Institute for Women's Health, with her role as an associate professor of gene therapy, as well as leading a team of research focusing on developing preclinical gene therapy and RNA editing treatments for childhood epilepsy, including Dravet Syndrome. Today's episode is going to dive more into her work on this and the applications of gene therapy in treating non-heritable genetic diseases. And if you don't know what any of that means, don't worry, because we're going to dive into it today. So it's such a pleasure to have you on this pod, Dr. Karda. Genetics is truly such an interesting field and my favorite. And I can't wait to learn more about your work today. So to start us off, please, can you tell us a little bit more about where this all started for you?
Of course. Well, thank you first for that lovely introduction, Olivia. And as you've said, I'm Dr. Rajvinder Karda. I'm an associate professor in gene therapy at the Institute of Women's Health at UCL. And to be honest, as a child, I always loved science. I think I used to look forward to going to my science lessons in primary and secondary school. And that kind of led me into doing a degree in biochemistry at King's College back in 2007, so a very long time ago now. And during that time, my passion for research really ignited. And so I continued my academic journey by doing a postgraduate degree in research at UCL as well, which was only at Institute of Child Health at Great Ormond Street Hospital. And this was really the first time I got involved into research that was with patients. And I started to understand that some medicines, like drug treatments, are often inadequate and quite limited to some of the patients who have these very severe genetic disorders. And so I started to get really intrigued and started researching a bit more into gene therapy. And so this led me on to starting my PhD at Imperial College back in 2012 now. And my PhD really involved looking into using gene therapy as a tool and looking for inflammation markers in a model for cerebral palsy. And during my PhD, I was really interested in trying to develop gene therapy for a very specific neurological disorder. And I came across Dravet syndrome from simply just researching and looking into different types of disorders there are out there. And back in 2015, there weren't many genetic therapies or people researching genetic therapies for Dravet syndrome, because we knew there was a huge unmet need, because Dravet syndrome current therapies were quite often inadequate, and the disease is quite severe with children with this disease. So after a lot of trial and error, I finally came up with some sort of genetic therapy for Dravet syndrome. And in 2019, I applied for a grant application. It was successful. And that kind of made me start, developing preclinical gene therapies and RNA editing treatments for Dravet syndrome. And since then, we've been able to use these kind of technologies and RNA editing technologies to develop treatments for other genetic epilepsies in children and other types of neurological diseases too. So yeah, that's me in a nutshell, essentially.
So cool. I think I love how that started, and it's so applicable, I think, to so many people's lives, where you kind of like see the more talked about diseases, when we're talking about careers in science or like careers in healthcare, you see the things that are often talked about, whether it's like in the media or you've just heard about it one way or another, but then these more kind of rare diseases that aren't just not talked about as much, but aren't researched as much, and the importance of kind of looking into that. So that's really cool. Okay, so then sort of to back up a little bit, for people that might not know as much about gene therapy, maybe we can get into that first and cover the basics. So further to that first episode that we did with Professor Waddington, let's talk about the different types of gene therapy. So I guess there's viral and RNA editing, and maybe you can touch on that a little bit.
Yeah, that's absolutely fine. So in order to explain gene therapy, we need to go back to kind of the central dogma of biology. And what I mean by that is that you have a DNA, which is essentially a genetic code, and that kind of forms RNA, and then that forms your protein and everything's all fine and dandy. But if you've got a genetic mutation, so mutation in your DNA code, you have abnormal RNA and then you have abnormal protein, and this leads to a genetic disease. So essentially what gene therapy does, it comes along and it removes that faulty gene or replaces it with a correct sequence in an individual cells of that specific disorder. And generally, gene therapy does use harmless viruses to restore the function of that DNA. And essentially what RNA editing does, if we go back to the central dogma of biology, it interferes with the middle bit, which is RNA, and therefore interfering with protein. So it's not directly impacting the DNA at all. Mm-hmm. So it's kind of fine-tuning the therapy to only work on a small part of the RNA and therefore affect the protein production. And in my team, we've developed this RNA editing treatment. And essentially, we also use it in a harmless virus to essentially edit the RNA in individual cells and have a long-lasting effect. Because if we use viruses, it's a one-off treatment, and therefore, in theory, it should have a long-lasting effect, as opposed to if we were using a non-viral therapy to do that.
Right. Yeah. I mean, it's all complex, but I think when you break it down, it becomes more clear. But then sort of like leading on from that of gene therapy, why, I mean, you insinuated towards it, but why is gene therapy important, like relative to other therapies that can be applied for different diseases? So in something that's like related to your genes, let's say, what is the benefit of going directly to that source?
I mean, that's a very good question. I think the reason why gene therapy is really important is because a lot of these genetic diseases, some of them are rare, some of them not so much, they have very limited or no treatment options. And if you do have treatment options, they're often inadequate. And a lot of these diseases cause very severe symptoms, and sometimes people have lifelong disabilities, and they do unfortunately die at a very young age. Gene therapy offers a potential treatment to try and cure or actually reduce the symptoms that these patients have, because there's literally nothing else out there. And so it's another way of trying to treat these patients, because unfortunately it's really hard to. Yeah,
it's sort of like, would you say that it falls into the field of preventative medicine, or not necessarily, because it's sort of like the diseased genes are already there, so gene therapy is going in to edit it? So it's almost preventative, I guess.
It can be, yeah. You can edit the gene, or you can kind of replace it with a correct sequence as well. So you could call it that.
Okay. Yeah, interesting. And then I guess in terms of like applications of gene therapy, so generally like you're looking at this specific to rare diseases, where else could this be applied, for example?
I mean, you can use it for non-rare diseases. I mean, cancer is not a rare disease. Cancer is quite common. I believe it's 1 in 3 or 1 in 4 people are likely to get cancer. And there are gene therapies developed for this. So it can be applicable for not just rare diseases. It really depends on where the need is.
Right.
Because a lot of these diseases have very limited treatments, and that's the problem. Current drug therapies are not effective, and therefore we need to use the technology that we have and really try to find a therapy that will be quite effective. And I think the beauty about gene therapy is that if you're using a viral gene therapy, it is a one-shot treatment. Because in theory, if you give it once, it should be there long-lasting.
Right.
And, we could touch upon the different examples later in this podcast, but that's essentially what gene therapy does. And so it's tailored to that specific disease, which is key. Because if you look at drug therapies, you get a drug treatment, and drug therapy tends to suppress the symptoms or alleviate them. It doesn't actually go to the root cause of the disease, whereas gene therapy will go to the root cause of the disease and try to rectify that mutation. And therefore, in theory, that should be a long-lasting effect than just getting a cocktail of drugs.
Yeah. And would it be applicable to the individual, so like based on their genetic sequence? Or when you say gene therapy, it's more of like a broad treatment that targets your genes, but it's not specific to the individual?
Yeah, that's a good question. So it really depends on the patient population. So if patients have all the same mutation, then we can use a very similar gene therapy applied to everyone. But if you have a disease where patients all have very different mutations, but do have a very similar outcome, similar symptoms outcome, then in theory you could use the same gene therapy.
Right.
But another scenario, if you have patients who have different mutations but have the same disease,
Yeah.
but have different symptoms, then we got to tailor the gene therapy for those individual patients, and therefore it becomes a more of a different type of therapy you would do. And in that kind of instance, you probably would go to use gene editing, for example, or even RNA editing to do that, because you have to make a more personalized medicine for that.
Right.
So it really depends on the disease, the patients with the specific mutations, and the types of symptoms they have. And as gene therapists, we really look into the natural history study of diseases to understand exactly how many patients have this mutation and how many patients present this type of symptom, and how that we can put that into our gene therapy and trying to find a treatment for it.
That makes sense. So it's like tailoring not just the actual therapy, but like the method of how that's going to be applied. So viral versus like RNA editing.
Yes.
Based on the disease.
Exactly. Because a lot of diseases have a spectrum.
Right.
And what I mean by spectrum is that they can have a different mutation or even have the same mutation, but present a complete different symptom.
Right.
So it becomes difficult then, because you're like, actually, we can't use the same gene therapy for patient A with this disease with patient B, because they're presenting different symptoms. And at that point, you need to be like, right, we need to make this personalized medicine, or actually use a different technology to do that.
Amazing. And then in terms of like, broadly speaking, the benefits of viral versus RNA editing, what would you say? Like if you were going to maybe give 3 key points of each, when you would use them, for example.
So viral therapies are long lasting.
Okay.
And, you know, the most famous case of where viral therapies has been used is for spinal muscular atrophy.
Right.
And spinal muscular atrophy is a very severe childhood neuromuscular disorder where patients present very severe symptoms such as unable to walk, unable to talk, they're unable to feed or breathe on their own, and they do die, unfortunately, by the age of 18 months. It's a very small lifespan these patients have. Mm-hmm. And so a gene therapy using a virus was developed. And this is simply by giving a single administration to patients. And after giving a single treatment, all these patients were able to walk, talk, eat by themselves, and all live past 18 months. And they're still doing follow-on studies with these patients. And in fact, this treatment was approved by the NHS in 2021. So this is readily available for children who were born with spinal muscular atrophy. So that's a very good example of viral therapy was used for a very severe neuromuscular disorder. Mm-hmm. Now, RNA editing, there's 2 things you can do with that. So in my team, we use RNA editing in a virus. So very similar to you would give one treatment, it'd be long-lasting. But you can do these editing as non-viral. Mm-hmm. And so these will be repeated administrations. So they could be they can also be for neurological diseases too, but it will be, you'd need to give it a few more times. It won't just be a one-off treatment. So those are the scenarios where you would use the different treatments depending on if you want it long-lasting,
right,
or if you wanted to repeat it to treat a disease over a period of time.
Okay. That makes sense. Thank you. And then in terms of like the actual timing of applying these gene therapies, so in Dravet syndrome, this is already developed. So it's like in early childhood, I guess the application would be of the gene therapy.
For Dravet syndrome?
Yeah.
It depends. So with Dravet syndrome, the patients do present the disease around 6 months to a year of age.
Okay.
And it really depends when they get diagnosed. So ideally, you want to give the gene therapy as soon as possible.
Right.
But there is 2 clinical trials, in fact, for Dravet syndrome. One is a non-viral, one is a viral therapy. And this goes back to what we discussed. So the viral therapy is using a harmless virus to deliver a sequence of DNA to rectify the genetic mutation in patients. So they are delivering this gene therapy very early in development, so from the age of 1 to 8 years of age. So there's a multi-center clinical trial. So this is happening in the US, UK, and Australia. Okay. Whereas a non-viral gene therapy has a larger age group. So you're administering the treatment to ages between 2 and 18 years of age, but you're doing 3 treatments over a period of 6 to 9 months. Okay. And you're looking at the following the patient, seeing how it's working. Okay. And the reason why that's happened is because these types of non-viral therapies have been used for Huntington's disease because those patients present it later in life. And these non-viral therapies have worked in different types of diseases too. So the viral therapy has gone early in development because the spinal muscular atrophy clinical trial, which I just discussed, they administer the gene therapy very early in development. The first, the youngest patient that received the gene therapy, I believe, was 8 days of age. And I think the median age was 21 in the last clinical trial paper. So what they've learned is that the earlier you go with viral therapies, the better the outcome. Right. So that's why the age group for the viral therapies is smaller than for the non-viral, which is 2 to 18 months of age, 18 years of age. Sorry. So you don't know. We're still looking at the outcome because they've just started. Yeah. But we do know from the non-viral therapy of Dravet syndrome, they've been able to reduce the seizures outcome in these patients. So that's a very good outcome for the Dravet syndrome community because it's working really well. Yeah. So you can see that there's different ages that they're administering it to, and it's all about understanding how these mechanisms work.
Definitely. And I guess like the other important factor that just came to mind as well is like in terms of the timing. So we said we were going to talk a little bit more about it. Maybe we can do that now, is diseases that are heritable versus non-heritable. Yeah. So Dravet syndrome is an example of non-heritable.
Yeah.
And so maybe like a background on what that means, really.
Yeah, that's absolutely fine. So heritable diseases happen when there's a mutation in your germ cells, and germ cells are your reproductive cells. So that means that this mutation will be permanent in the child's DNA and therefore will be passed on to the next generation. Non-heritable mutations happen in somatic cells, and essentially these cells are non-reproductive cells. And these mutations happen by environmental factors or happen if there's some sort of issue with DNA replication that's occurred during development. But these mutations are not passed on to the next generation. So that's the difference. And with Dravet syndrome, 90% of the patients have sporadic mutations that cause the disease itself. Yeah. And that's what the difference is between the two.
Yeah. That makes sense. And so that's why you would see the disease presenting. I guess that's part of, what leads to it presenting between 6 and 12 months of age, you said.
Yeah.
And then in terms of so 2 questions off of that. So in terms of the gene therapy that you are administering to a child, let's say, is it different depending on if it's a somatic cell? So if it's a non-heritable disease versus a heritable disease, would the gene therapy be effective if it's heritable? Can you do that to reproductive cells, for example?
So that's a good question. I think it's two questions you've asked there in terms of talking about heritable diseases and using gene therapy and whether that affects the reproductive cells, right? Yeah. So it's 2 different things. So the first thing is the gene therapy of heritable diseases is the very good example was spinal muscular atrophy. Right. So as I mentioned, and I think we talk about it quite a lot because it's such an amazing study that's happened, and it's something that's unheard of with these children, is that spinal muscular atrophy is very severe, that as soon as a child is born, it will start to present the disease. Right. And so they used a gene therapy for spinal muscular atrophy, as I mentioned, which is a virus form, and gave a single administration to patients very early in development, and they all were able to walk and talk on their own and live past 18 months, which is amazing because that's never happened before. So that's a good example where you can use gene therapy for heritable disease. Now, using gene therapy to target reproductive cells is a very different subject because that can be unethical because you can't really mess around with those things. And, there's studies that have ongoing where in preclinical using animals to look into if you are trying to treat a disease, are you targeting reproductive organs? Because that's something we don't want to do. Yeah. And those things we do look into as researchers is we look into the reproductive organs and see, are we infecting this with our gene therapy? Because essentially we don't want to do that. What we want to do is actually treat the disease itself. Right. So these are things that we do look into. So we don't use gene therapy to treat reproductive cells. Yeah. What we do is treat the disease that has happened because there is a heritable, I can't say the word now. It is heritable. It's a heritable mutation that's happened, and therefore it's caused this different type of severe disease, and that's what we're trying to treat.
Yeah, that makes so much sense. And then, in terms of targeting your therapy towards non-reproductive cells, is there a way that you can do that?
Yes, I mean that's kind of what we do with all of the gene therapies, right? So, with spinal muscular atrophy, I keep going back to this, is because it's a very good example to use. It's mainly caused by motor neurons. So it's your neuron cells that are defective.
Yeah.
It just so happens that this mutation has been passed on from two parents who have a recessive gene for this particular SMN1 gene,
Yeah.
and therefore the baby's born with spinal muscular atrophy.
Right.
And it's really the motor neurons that are affected by this. So those are they're not reproductive cells, they're actually neurons that are being targeted. And so therefore you are using gene therapy to fix a mutation that is not in a reproductive cell. And in this case, it's a motor neuron cell.
Right. Okay. Wow. I feel like I've learned so much in the last 20 minutes just from that. I guess circling back to Dravet syndrome, and your applications of gene therapy in here, I think we haven't necessarily established what currently is happening in the field of that and in your research work in particular. Where are we at right now? Are these things that we're actually applying in clinic? Is it, part of a clinical study, or what's the status?
Yeah, so currently there are many different groups around the world that have developed different types of gene therapies for Dravet syndrome. And two of the preclinical projects are happening in my team. So we've developed a viral mediated gene therapy. So both of them are.
Yeah.
One is targeting DNA, one is targeting RNA.
Okay.
And so at the moment we have developing the treatment so that we can get all the right experiments done to make sure both our treatments are effective before we take it onto a clinical trial. So we're about 4 years away from getting to that point, but I'm hopeful that we can get this done because, there are many patients who are affected by this very severe disease. Now, as I mentioned, there are two different types of therapies available in the clinical trial at the moment. So one of them is a non-viral therapy. That's the one that's been administered to patients between the age of 2 to 18 months, and they've shown some very good outcomes where they're able to reduce the very severe seizures that are happening in patients. And they're just about to start the gene therapy clinical trial for Dravet syndrome, which is recruiting patients from the age of 1 to 8 years of age in the US, UK and Australia. So like I said, this is a very exciting time for patients with Dravet syndrome and the Dravet syndrome community because, we know that it is a very severe childhood genetic disorder, and we know that current therapies are often inadequate and, they can, anti-seizure medications can suppress the seizure frequency, but the seizures are still there, but you still have this developmental delay and cognitive delay that does occur with this disease as well. So I'm very glad that there's different people working on it. I'm glad that we're working on it and we're trying to work towards trying to get this to patients as soon as possible.
Yeah, definitely. And then I guess the other question that I would have, like in this field of Dravet syndrome, is there something that you find, or even just gene therapy in general, is there something that you find is a common misconception, whether it's with colleagues or it's with, your friends or family who maybe don't have a background? Like, do you find that there's anything that people will commonly just sort of assume, but, isn't true necessarily?
Yeah, I definitely. That's a very good question because one of the things that they probably would have misconceptions about is because when you talk about gene therapy, you discuss viruses. And as soon as you hear a virus, because of the COVID pandemic, everyone's like, what is that? And it's almost a really bad thing.
Yeah.
But if you don't know about gene therapy, you would assume the worst of it because it's a virus. But actually, in fact, it's about educating everyone around you and educating the lay audience. And also, a lot of parents who may not know about what gene therapy is.
Yeah.
And also just letting them know that it's quite safe because there's many different clinical trials going on for gene therapy at the moment and non-viral gene therapy, both viruses and non-viral. So there is a lot of data coming out showing that how safe it is and how it is very effective in trying to treating very severe neurological disorders, all the way to treating cancer and different types of therapies too. So it's all about feeding that information to the lay audience and letting them know that actually gene therapy is okay.
Yeah.
And it can be applied to many different disorders and help them in the long run.
Yeah. And I guess also like really kind of clarifying that point as well of like this is being applied to your somatic cells versus reproductive cells. And, I feel like there's importance in like identifying and separating those two things.
Definitely. And it's about having these kind of conversations. We really inform that to the wider audience because, it's really important to do that. As gene therapists, we do get involved with a lot of patient groups because that helps us to feed in information to our research. Because we need to understand is, okay, how is this affecting the individual? How is this affecting their parents? So do we need to inform their parents too of what's going on? So it's a lot of people involved into developing in gene therapy. It's not just what your research is, it's a bigger picture. We need to make sure this is everyone around it works and everyone understands what's going on as well.
Definitely. It's so important. And then also I have a question for you about, your specific field of study. Like you said at the beginning, when you were kind of getting into this and you saw the importance of looking into rare diseases that maybe aren't as studied. Was that hard, like getting into a field that, isn't as maybe funded or a field that isn't as focused on or there isn't as many years of research? I mean, I'm sure that it presented unique challenges. And do you have advice for anyone who, maybe is thinking about getting into that field or just interested in, maybe doing something that isn't done often?
Yeah, no. Definitely, I would encourage everyone to do it because, at that time I was quite junior in trying to understanding what gene therapy was. I hadn't finished my PhD at that point, and I didn't really know much about genetic epilepsies because my PhD had nothing to do with that. And so really what I started to do was Googling. I used Google quite a lot and Googled, epilepsy experts at UCL. And I did a lot of door knocking. I went around UCL, said, hello, I'm Raj, can you help me with this? And it was literally that. It was me going around just talking to people and people were like, who is this person that keeps coming around everywhere? But I was quite determined that I wanted to learn. I wanted to understand this. And that didn't put me off in terms of there wasn't any research done. But I was like, well, if there isn't, someone's got to do it. We've got to figure it out. We have to figure it out. And it came to really establishing collaborations around everywhere because that's really key. It's like, feed information to what I need to learn, and therefore I can understand how we're going to do this. And so that took many years to do that. It's really knocking on doors, trying to get, doctors who work with patients directly at Great Ormond Street Hospital to work with you. So that really fed into the whole research. So it took a bit of time, but I would tell people to not give up. It just literally requires a lot of going out there, networking, speaking to a lot of people, speaking to some experts in the field, getting as much information as you possibly can do to really formulate your ideas, and honestly, it will be fine. I've done it, and many other people have done it too. But it honestly requires patience and a lot of networking.
So good to hear. Okay, and then I guess to wrap things up, I mean, in the field of Dravet syndrome in particular, what are you hopeful for? Like, what are you hoping to see? You sort of mentioned, in the next 4 years, you're hoping to get it clinical. Therapies. I guess that would be what you're looking for. But, even beyond that, what is the future of Dravet syndrome and epilepsy, childhood epilepsy and gene therapies look like for you? Yeah.
I mean, as I mentioned, with Dravet syndrome, I'm terribly excited about how the field's moving, because there's 2 treatments already in clinical trial, for Dravet syndrome, the non-viral and the viral one. And we're developing some treatments too, and hopefully we should get that into clinic in the next couple of years. And there's many teams across the world who are working on different types of therapies for Dravet syndrome. So it's a very good, it's an amazing time to be working in gene therapy, but also you're seeing these really great outcomes from these clinical trials. So it's really beneficial for the patient, because that's the main thing, is we're doing this to benefit the patients with Dravet syndrome, because, there's no other treatment that's working effectively. Current drug treatments aren't working really well. So in terms of the field, it's moving in the right direction, I believe. And I think as time moves on and as technology starts to develop, we're starting to see that we can apply these gene therapies for many different disorders. So I think the field of gene therapy is going to move and is going to vastly improve because so much is changing. As I mentioned, there's your traditional gene therapy where you use viruses to replace a defective gene, or using non-viral therapy to manipulate DNA. But you've also got, new technology like gene editing, RNA editing, where you can make much more precision medicine and try to treat different diseases. So I think it's just gonna continue to grow. And I honestly believe, in my lifetime at least, I think you'll be able to buy gene therapy over the counter for something, for sure. I think you will be able to.
So cool. You heard it here first, guys. Thank you so much for coming
You're
on.
welcome.
It's been so great to
It's been
learn from you.
No, you're welcome. Thank you for having me. It's been a really great chat.